Hello everyone, today Health Ninja is going to talk about the ectopic pregnancy. Ectopic pregnancy is defined as implantation of a conceptus outside the uterine cavity. The incidence of ectopic pregnancy is about 1% of all pregnancies. The estimated death rate is around 1 in 300,000 ectopic pregnancies. What are the risk factors for the ectopic pregnancy? Previous laparoscopically proven pelvic inflammatory disease, pelvic infections like chlamydia trachomatis, previous ectopic pregnancy, previous tubal surgery, subfertility, intrauterine device use, progesterone-only pill, induced abortion, endocrine disorders, assisted conception, smoking. Sites for ectopic pregnancy is uterus, fallopian tube. In the fallopian tubes, the distribution of sites of implantation are the ampulla 74%, isthmus 12%, fimbrial end of the tube 12%, and interstitium 2%. Other sites are abdomen, ovary, cervical area. Out of the second month to the end of the third month of pregnancy. Most of the early symptoms are like that of normal pregnancy, such as missing your period, nausea, breast tenderness. Early warning symptoms include vaginal bleeding, abnormal uterine bleeding, pain in the shoulder tip. The pain starts where the shoulder ends and the arm begins. Lower abdomen pain, frequent urge to poop. Examination, anemic symptoms can be seen. On abdominal examination, generalized or localized mild tenderness, occasionally guarding and rebound tenderness can be detected. On bimanual examination, tenderness in fornices, cervical excitation, a tender boggy mass in the pouch of Dougal's. Uterus may be slightly enlarged, but its size does not normally correspond to the gestational age. Acute presentation with rupture and massive intraperitoneal bleeding, hypovolemic shock, acute abdomen. Investigations for ectopic pregnancy is listed below. Blood pressure, pulse, temperature are observed. As laboratory tests, hemoglobin, blood group, beta-HCG is investigated. If beta-HCG levels below 5 MIU/mL is negative. If beta-HCG levels above 25 MIU/mL is positive. Suboptimal rise suggests ectopic pregnancy, but levels vary widely. In a normal pregnancy, beta-HCG levels typically double every 48 hours. In an ectopic pregnancy, the rise might be slower or even plateau. Transvaginal ultrasound visualize an intrauterine gestational sac at 4.5 weeks. No sac with high BHCG suggests ectopic pregnancy. Free fluid suggests rupture. In around 20% of ectopic pregnancies, fluid buildup in the uterus can mimic a gestational sac. Laparoscopy is done for diagnosis and treatment. Ectopic pregnancy can be managed using an expectant, medical, or a surgical approach, depending on clinical presentation and patient choice. Expectant management is an assumption that a significant proportion of all tubal pregnancies will resolve through regression or a tubal abortion without any treatment. As medical management, methotrexate is used for specific cases. Indication and adverse drug reaction should be considered. Surgical treatment can be by laparoscopy or laparotomy. During surgery, the fallopian tube can either be removed, which is called salpingectomy, or a small opening can be made at the site of the ectopic pregnancy, extracted via the opening, which is also called salpingotomy. Salpingectomy preferred if the other tube is normal,